I wanted to add a little part. I know you just took CPR, but I wanted to add a little part on the numbers and make it applicable for first responders for EMS. So we're going to look at the assessment, the steps, rate, ratio, hands placement, depth, adult, child, and infant. Some things to remember in using an AED that contribute to how you're going to integrate CPR into the EMS world. So since 2010, American Heart Association, kind of the leading standard on science-based evidence for the best outcomes with CPR, first thing we want to do is check the scene for safety. If somebody was electrocuted, if they were involved in an accident, there's something that could be at risk for you to walk into that scene. So check the scene first. Shake and shout the victim. They appear to be unresponsive. See if you can get their attention and touch them. And as you're doing this, kind of look for that chest moving. Listen for any kind of noises. Check that pulse. The sooner you check the pulse of the carotid artery in the adult, the faster that you can determine that there's not one, and the quicker that you can start compression. So this person has been laying there maybe for minutes without their pulse, without their heart beating. And so the faster that you change that and with your compressions actually create a pulse, the person has the better outcome. So we're going to check that pulse for 5 seconds, no more than 10. Now we don't use our thumb, we use our 2 fingers, the second 2 digits, making sure that if we use our thumb, we actually have a pulse in our thumb, and we could think we feel a pulse. So if you think you feel a pulse but you're not sure, we go ahead and say no pulse. No more than 10 seconds. If no pulse, activate whatever kind of response. Maybe it's an ambulance, you're a first responder, maybe it's a backup crew, maybe it's fire rescue, somebody else, because the 2 of you on a crew cannot take care of that. And start compressions. Think about it like this. You can probably hold your breath for a few minutes, or at least a minute, but you can't go very long without your heart beating. So stay on the chest, continuous cardiac compressions. Actually, American Heart says those who get the most compressions are the ones who live. So place the heel of one hand between the nipple line. If it appears the nipple line is kind of saggy, and I don't want to be crude, but if it's an older lady and the nipple line is low, just you're going to be on the lower half of the sternum. Stay away from that little notch called the xiphoid process, right there where the ribs come together at the inferior portion. If that breaks off, it goes right into the liver and causes it to lacerate. Place the other hand on top of the first hand so that you can compress down about 2 inches. The first couple of compressions, you may feel cartilage kind of making some noise, just like knuckles do when you pop them. That's not broken bones. You'll know when you break a bone. It's a true snap. As you come up from those compressions, make sure you have full chest recoil, that you're not pushing halfway down, because what you're doing is pushing the blood out of the heart by squeezing the sternum, the breastbone, towards the backbone, and then by relaxing, allowing it to completely refill. All of the valves in the circulatory system keep that blood moving in one direction. That's why we want to see good chest recoil. Person needs to be on a firm surface, so if they're in bed, drag them to the floor. Compress 30 times at a rate of at least 100. So the sweet spot is going to be 120. And if you count 1 and 2 and 3 and 4 and 5 and 6, at least in your head, don't count out loud, you'll get tired that way, that's going to be the correct rate. After 30 compressions, pause for no more than 10 seconds to give 2 ventilations. We talked about that in the previous lecture on airway, that you want to use an airway mask of some sort, whether it be a pocket mask like a mouth mask or a bag valve mask. In fact, if you don't have a mask, if you don't have a barrier of some sort, it's actually better that you don't do any mouth-to-mouth and you do continuous compressions until other help arrives. You're going to do 5 of those cycles. 30 to 2 is 1 cycle. You're going to do 5 of those cycles in about 2 minutes. After 2 minutes, after your 5th cycle, you reassess by checking the pulse. At the same time, respirations no more than 10 seconds. Then it's time to rotate the rescuer. So kind of think of a CPR response team like a pit crew. Everybody's got one role. If you've ever watched any of the car races, everybody's got one role. So my role is 30 to 2, 5 cycles of compressions, 2 minutes. Well, if I do it really good, I might get tired. So I'm going to have somebody else take over that role, switch those rescuers so we don't get tired. All of the compressions stay really effective. When the AED shows up, we want to go ahead and use it. Continue your compressions. The second rescuer, we remove the clothing. So compressions are still going on while we're attaching this. We turn the AED on. First thing we want to do is turn it on. Number 1, we turn it on because it's going to tell us what to do. Number two, if I attach the electrodes and do everything else and turn it on, it's going to give me about 20 seconds to do all that stuff I've already done. It's designed, it's a computer, but it's designed to not cause stress. So you can imagine if we turn this thing on, it's like, attach electrodes, attach electrodes. Why haven't you attached electrodes? Kind of reminds me of a GPS system. Even when you miss your turn, it's very nice and says, you know, at the next intersection, make a legal U-turn. It's very nice to you. Turn it on, attach the electrodes to the chest. And it's preferred that we do sternum and apex, so to the right of the sternum, under the clavicle or the collarbone, and the left one on the ribs, straight across from it. Some of them are designed to be put on below the nipple line in the front and below the shoulder blade on the left side in the back. Then plug in that PADS connector to the AED. What it's going to do now is analyze, and it'll tell you, analyzing heart rhythm. Do not touch the patient. So we don't touch during that time. But when it says shock advised and it's going to charge, a lot of them are designed to take more than 10 seconds to charge, and that's a good time for us to get back on the chest and do at least a few more compressions. And communicate very well with whoever's pushing that orange button. It's usually flashing, because you don't want them to press the button as you're still touching the victim. As soon as we deliver the shock, one shock, we get back on the chest, and we're there for 2 minutes. Now the AED is going to take care of your time. You continue compressions for 2 minutes. Be careful though. Make sure no one is touching the victim when you shock. If they have a medication patch, put your gloves on, make sure you're wearing gloves, and remove that patch, wipe it dry. You never want to put an electrode, an AED patch, over a medication patch, as well as implanted devices. So if they have like an internal AED or pacemaker, what you'll do is you'll block the electricity going through the heart muscle, and you don't want to do that. If your patient's laying in water, water is a good conductor of electricity, so you want to pull them out of that puddle, dry off the chest, and then you are able to defibrillate. So that was the adult. For pediatrics, child is much the same. We check the pulse at the carotid artery in the neck, place the heel of one hand between the nipples, and now sometimes people say, I have the one hand and that's as far as I need to compress. I don't know what to do with the other hand. If you find yourself in that situation, it's okay if you put 2 hands on the chest, especially if you're smaller. You're going to compress about 2 inches. Remember the other one with the adult, at least 2 inches, so really deep. This one, if you look at the anterior-posterior diameter of the chest, we're going to compress about 1/3 to 1/2 of that. You're not going to break the ribs on kids. Their bones don't fully solidify until they're older, so they're pliable. We're going to compress again at a rate of at least 100, that sweet spot of 120. And I like this change with the new guidelines 2015, because some people did a heart rate of 180. Well, that's not effective either if you go too fast. So over 100, but 120. One rescuer pediatric CPR, we're going to do 30 to 2, but since they're more compact, if we have 2 rescuers, one person at the head with a pocket mask or a bag mask, and the other person on the chest, we can do a 15 to 2 ratio. And we still do the full 2 minutes before we change our rescuers or think about AED use. For the infant, check the pulse now at the brachial artery in the arm. The neck's a little harder to find a pulse in. Place 2 fingers, 1 finger width below the nipple line, just like you learned in CPR class. If you do 2 rescuer CPR, sometimes the 2 thumbs and circulating technique is a lot easier. You don't tire out as fast. And we're going to compress at least 1.5 inches, and again, 1/3 to 1/2 the anterior-posterior diameter of the chest. Same rate, at least 100, with that sweet spot of 120. 1 rescuer 30 to 2, 2 rescuers 15 to 2. So something that takes you a little bit further than CPR class. So let's say that you have someone that you're resuscitating. They're not dead until they're biologically dead. They're clinically dead, but they're not biologically dead yet. And you use an AED, you get through 3 no shock advices. Go ahead and transport. You're probably not going to ever have somebody that regains a shockable rhythm. If you get 6 to 9 shocks, you're like, wow, we just keep shocking and shocking and shocking. We can't stay here forever. Go ahead and transport. If they regain their pulse, as soon as they do, check for breathing. If they're not breathing, take care of that. Ventilate for them, but get them going so they don't lose that pulse again. Don't take off your electrodes. Keep the AED attached to it in case you need to use it again. Some companies only carry 1 set of electrodes, and then if they go back into cardiac arrest and you remove those, that's it. There's no putting them back on. There's too many hair and oil on them. You can't analyze with an AED in a moving vehicle. So if they do go back into cardiac arrest, you're going to have to pull over. It'll actually tell you to stop motion. We've started CPR, but when can you stop? Well, if the guy sits up and says, hey, please get off my chest, that's a good indicator. Well, they're not going to do that, but they're slowly going to start waking up, maybe start moving. That gives you an indication you should check a pulse and you should stop. If a physician, sometimes a justice of the peace, depends on your area, directs you to, either in person, on phone, by radio, or your protocols to say, you can do 20 minutes of CPR and then contact online medical control and call it. That could be a protocol. Someone of equal or higher certification takes over for you if the advance directive that you didn't know about arrives. So if that happens, make sure you contact online medical control, let them know the situation, and then get their blessing to stop CPR. If for whatever reason the scene becomes unsafe, you need to leave and you can't drag that victim with you, so you can stop. If you're the only one doing CPR and there's no help coming and you say, boy, if I do 5 more compressions, somebody's going to have to stop by and do CPR on me, then you can stop. But you can't start CPR. They vomit, they have loose stools, you decide, oh, this was a mistake, we got to stop. No, you need to contact online medical control if you're going to do that. After the run, realize that most people who die stay dead. But some people who get the fast response, which is a witnessed arrest with a first responder CPR, that's why we like to go in the communities and teach the families of victims CPR. That's lovely when you show up and there's somebody in the family who started CPR. For the most part, though, you just see people standing outside waving you in and they're laying there dead. They've already gone 10 minutes without oxygen. Their chances aren't as good. One thing to know, though, you jump into every code as if this is the one. Even to say only 10 out of 100, 1 out of 10, however you want to look at it, are going to actually regain a pulse and be discharged from the hospital. You have to look at each and every one and say, this is it. This is one that's going to make the difference. Otherwise, you kind of go in with the attitude, this is kind of futile. Put your heart into it and try the best you can. You're the only thing between them and the grave. If you stop, the results are inevitable. So just wanted to do a little recap on CPR and maybe tie up some loose ends that make this more kind of personal to EMS rather than just your CPR class.